Thank you very much. We've got a few minutes for questions. Can I ask David and Mark to come back and move to the microphone?
Yes, my question's to David. What do you personally do to live a long life?
Now, I hope you've all read Victoria's profile, because I think that's a leading question.
Is this on? So you're assuming that I do. I did try calorie restriction for a week, and I gave up. It was horrible. I don't like the feeling of being hungry all the time. I don't think anybody really does, except for maybe a handful of people who do this regularly, and they've convinced themselves actually that that's pleasurable. So what do? I do what everyone else should be doing. I try to exercise a little bit. I try to watch what I eat. I avoid sugar like the plague if I can. I stopped eating dessert at 40. And yeah, so my life sucks.
But it's worth it. Next one.
John Carney, Queensland. Alison, thank you very much for your explanation there. And it certainly appears that cognitive impairment is occurring at an earlier stage than a lot of us realised. The problem with the regulator, though, is that there are a lot of instances where the regulator has been quite draconian in the way they have treated problems with doctors, and it discourages disclosure at the moment. And I hope that APRA lifts its game in the way they handle complaints from colleagues and patients.
I can't speak for APRA. I don't work with or for APRA, but I think that the regulatory landscape has changed considerably in the last 20 years or so. And we need to get away from this mindset that you're making a complaint about an individual. In fact, when I worked at the Medical Board in New South Wales, we used to talk about it, the C word. We didn't use the C word. It was a notification, not a complaint. If you're concerned about a colleague, you're not complaining about them by bringing it to the attention of the regulator. You are bringing them to the attention of the regulator so that they can do their job with the powers that they have. And I would be very surprised to find that in this day and age, those powers are being used in a draconian way when you are dealing with an impaired practitioner. I think that the focus of regulation in this day and age is compassionate, it's fair, but it does the job it has to do. Regulation is there to protect the public, and if it's felt that a practitioner is posing a danger to the public because of their behaviour or their impairment, then something needs to be done about that. But it's done in a way that maintains the doctor's dignity as much as that is possible, and it is done in a reasonable and compassionate way. As I say, I don't work for APRA, but I would be very surprised to find that it was anything other than the way I've described it, if we are dealing with a case that is purely about impairment. And don't think in terms of making a complaint. What you're doing is passing on a problem that you can't solve yourself to somebody that can, and to somebody that can solve it with legislated powers which will be exercised in a reasonable, dignified and compassionate way.
Thank you for that. Over there.
Thanks. Philip M. the paediatrician. Like many people in the room, I belong to Avant, and I'm younger than some, a bit older than others, but I've been receiving for the last 2 years letters from them suggesting that if I retire, they'll pay me a few $1,000s, not a huge amount. And I've never been sued, so I haven't cost them much money. So I'm just wondering, is this a commercial decision that's been made, or what do they know that I don't know?
For the Canadians, Avant is one of the medical protection organisations or medical insurance, medical indemnity organisations.
I'm Jo Flynn. I'm chair of the
Do you want to
National-
comment?
Look, I didn't even. I'm very surprised that a company would do that in an environment where, in fact, we actually are relying on our more senior, particularly in an environment where we're relying on our more senior doctors to provide training for a very large number of trainees coming through the system. I think they would be better off investing their money in supporting the senior doctors if there is concern, and raising the possibility, making people aware about cognitive impairment. It's not hard to screen for cognitive impairment. You know, and the population, if you're over the age of 75, you've got over the age of 85, you've got a 1 in 4 chance of having a dementia. That's the population. You know, I think there have to be, you could do other things than just give people money and say get out, which I think sounds awful.
And from a regulator?
I'm Jo Flynn, I'm Chair of the Medical Board. I just want to take up the comment made by John Carney about draconian. In disclosures, first of all, I've just had my first of those letters from Avant, so I've obviously crossed some threshold, which might be to do with the fact that John and I graduated 40 years ago. I mean, I think it's a really important thing to unpick this a bit. So the Medical Board works with AHPRA and deals with complaints about doctors in jurisdictions other than New South Wales, and now in the last couple of years in Queensland as the first port of call. And there is no doubt that any doctor who is the subject of a notification to their regulator feels awful. And I think there's an irreducible minimum of distress that anyone in that situation will feel, which is not to excuse or say that we don't have a responsibility as the board and AHPRA to do everything we can to make those processes as timely, as respectful, as efficient as we can. But we know that there have been difficulties in those processes, and we know that they've taken too long and people have felt very lost in the process. So there's an enormous body of work going on in the jurisdictions where AHPRA is the regulator with the board to improve those processes. So we've significantly reduced the length of time it takes to assess a notification to decide what's happening with it next. We've significantly reduced the mean length of time where matters are open. And we've got, I think, a more highly skilled and targeted approach amongst the staff in terms of what to do. So, I mean, the regulator absolutely has a responsibility to do those things as well as we can, and we're about to start systematically collecting feedback from people using probably a third-party provider about, you know, what it was like for them to go through the process of being subject to a notification, and we will publish those performance results and seek to improve them. But I do think that, you know, there are issues. We don't like feedback at the first level. We certainly don't like somebody looking at us, and it's part of the wider culture of medicine which has come up in many ways today, that we just have to get a bit tougher about recognising behaviour that's not appropriate, performance that's not appropriate, and doing something about it. And then we have to look to those, including the regulator whose responsibility it is to take the next step and demand that they perform well, and those of us who are in that world are doing our best to make sure that happens.
Thank you very much. 2 last questions here from one of my fellow geriatricians.
Retired one. I suppose my understanding is we're in medicine to help patients, and our responsibility is a safe environment for our patients. And I think the perception is that doctors protect doctors. And so our first duty is back to the patients. And those people who have been involved in dealing with impaired doctors and being responsible and supervising them will realise that that comes at a huge cost to themselves, depending on the severity of the impairment. And just what the regulators are looking at in their kind approach, and the question of trying to retrain people and the time period, the timeliness of this. You know, I've seen this process take 2 years before somebody's come back and say that they are not retrainable or their behaviour cannot be changed. So what protection of our patients at the balancing of being kind to the doctor.
And I'll just ask, sorry to cut you off, I'll just allow Alistair his question, and then we'll have any last comments.
Mine's primarily particularly to Alison, the association between social practice isolation and the impairment. I just wonder if that's it was so profound in that early slide that you showed, whether it's an actual cause and effect association, or do you think there's that there is a greater prevalence of solo practice in the passing generations of primary care physicians, rather than it being necessarily that they seek solo practice in later life.
Alison?
Yeah, I don't suggest that they seek solo practice. I think that if they find themselves in solo practice, they are much less likely to be exposed to the things that would keep them safe in practice and to keep them performing well. They don't have the opportunities for interaction with their colleagues, perhaps are not as attentive to their CPD, don't pick up the cues and clues from their colleagues that perhaps they're getting a little bit past it. They don't go there to avoid those things, but once they find themselves in solo practice for whatever reason, I think that it has a deleterious effect on their practice and their ability to sort of monitor and maintain their competence and their performance.
Thank you very much. Mark?
Just to comment on this concept of the impaired practitioner who comes to attention, and I think the driving analogy is really interesting. On the data that we've got, about 89% of older people who have got cognitive impairment choose to stop driving at an appropriate time. And it's only a subset of that population who try or need to continue driving, and there are all sorts of similar drivers. So if there's nobody else in the family who can drive and they're living in an isolated regional area, then they're more likely to, hence the solo practice stuff. So I think it's important to put in perspective the population who would come to the attention of a regulator with cognitive impairment versus those who might develop cognitive impairment and then be aware of that. And I think that if they do have colleagues around them, it's more likely to be fed back to them. And so I think that's another drive for that solo practice. So I just say that just so that people don't believe, that sort of get a too negative view about the profession and where we take it, because it's a subset.
Thank you very much. We've had the full range, so you know how to start running, stop eating, watch out for whatever the latest thing is. I'm still waiting. It was at the beginning of my career, it'll be at the end of my career before we have the cure, but I remain hopeful. Look after your patients with cognitive impairment and retain your insight, or ask your colleagues about your own medical practice. Can I thank our three speakers?